This patient is presenting with leukocytosis 3 years after. There is a differential diagnosis for leukocytosis. The differential diagnosis can vary from something that's very simple, like an infection process, to acute myeloid leukemia. So I think the first thing, one would obtain a good history and physical exam, see in what setting the leukocytosis had happened. When the blood counts are ordered, one should look at the differential of the white blood cells. Ideally get a manual differential and a blood smear to review, because what dictates the further workup is the type of leukocytosis. Is it neutrophilia? That would indicate infection or a chronic process. Myeloblasts increased, that would make the diagnosis of AML and so forth. So in that setting, if it's neutrophilia, one would look for infections. One could look into myeloproliferative diseases if it's persistent. But if it's the blasts that are increased, that would obviously lead to diagnosis of acute myeloid leukemia. So the next step would be obtaining a bone marrow aspirate and biopsy and making the diagnosis. Nowadays on the bone marrow aspirate and biopsy, it's complemented by flow cytometry testing, where we can identify the myeloblasts in more accuracy than just the morphology, although the morphology remains the main part to determine the percentage of the blast. And cytogenetics are a must in testing when we do the bone marrow aspirate and biopsy, because the risk stratification for patients with acute myeloid leukemias are based on the cytogenetics. And nowadays, we even go further to look at the level of the somatic gene mutations by next generation sequencing. There are at least certain mutations that are incorporated in the risk stratification for patients, and there are available therapies nowadays for those. So the testing for a FLT3 mutation, testing for MPM1 mutation, CEPP alpha mutation, which is favorable mutation, IDH1, IDH2 mutation, is becoming routine for those patients. First, it has value in risk stratification. Second, nowadays there are targeted therapies, or the treatment could be tailored based on those mutations, which in many cases, actually, when we see those patients referred to us from the community, are not tested. So we always obviously focus on the disease and what tests we need to get for the disease, which included the things we discussed. But I think also we have to look at the patient, the performance status for the patient, and the comorbidities, because that will determine some of our choices for treatment and the immediate stage, and also down the road. So typically, if we are thinking of intensive chemotherapy, we have to obtain baseline of cardiac function. Kidney functions are important. If the leukemia is proliferative, sometimes with hydration and medications for hyperuricemia, we can improve the kidney functions, because high creatinine can dictate the treatment, but also can predict the morbidity and mortality with treatment. So those patients that have renal failure, would do worse with intensive chemotherapy in general. Simple things also, obviously, looking at the liver functions, making sure that the patients don't have, transaminitis that would require adjusting the medications or the prophylactic medications for infection.